looking for when I asked the question. I specifically said, tell me now what nervous, but the psychiatry. How does this affect patient who has psychiatric problems, the CNS? How patients with psychiatric problems, the CNS, how does it happen?
The side effect of medication.
The side effect of medications, like what medications?
Especially
Right, excuse me. The nervous system, right?
yes.
We know it into two parts, central and peripheral nervous system. You are given different things that can cause problems in the nervous system, right? One part of it was psychiatry, wasn't it? So I'm asking you basically, what part or what roles the different sections or the categories that we spoke about, how does it affect the patient in psychiatry? That's all I'm asking. I'm not asking you about, tell me about Parkinson's, tell me about ALS, and I'm not asking that, I'm asking about psychiatry. Central nervous system, psychiatry.
Central nervous system, psychiatry.
Right, critical thinking. How this happened, you know, I'll give you John Hopkins and gives you all that here. Think about it, put it together. Because that's what you should have done, I told you last week, right? Put it together.
Oh. It's
What?
true. Okay.
It affects the person's
Your capacity to think that your ability to make decisions, to connect with the
Like they can't think straight.
Yeah, but how? You don't just say they can't think straight.
Okay.
How this happened? What's the rationale? What's the reason? Remember all the questions of
You know,
why? What caused it?
the
The one with the diabetes.
you know the inability for the peripheral nervous system to send messages to the brain.
All right. In that same thing, they talk about disruption of,
Signals.
right? But we're not talking about that right now because that disruption is a whole different thing. What the psychiatry in the central nervous system?
What about the medication? The medication can make them, like they can't think straight. But I think about the medication, right?
Medication can cause lots of problems, and you're absolutely right, but that's not what we're looking for. That comes after.
So the visualization is Alzheimer's disease. That's what I said.
I was thinking about depression, but I don't know if that's what you're looking for.
Blood pressure, high blood
All right. How does high blood pressure cause a problem?
It's like when you have
Trauma.
What?
when you have high blood pressure, your arteries, the pressure of the blood on your arteries is too high for the heart
Right.
to move it. So sometimes it results that you have a bulge in your artery that for aneurysm. Sometimes not because of the brain, you have aneurysm in your brain. So all this can be dysfunction in there. And it can cause problems.
What type of, you said that you can have a problem in the brain, like what? What problem you can in the brain?
Like because it's very repetitive, like the communication is not
You can't communicate clear.
communication like when you have the aneurysm, sometimes it can be forced, and you can you're gonna have a problem of thinking and everything. You have to get sick and everything. All of that can cause.
You're going in the right direction, but the only thing that you're doing is that you kind of mixing things up and not being, very specific to this whole thing. You're talking about the artery getting aneurysm, like cerebral aneurysm, bursting, causing problems with person thinking process. When you look at that I give you, trauma. A person had a motor vehicle accident and they hit their head. They get TBI, traumatic brain injury. Now these persons can what? Make decisions. This person's way of thinking has significantly changed. Person gets hit in the head with something. And then we look at disruption of blood flow. This is what you were talking about just now. Disruption of blood flow, which is different. And then next to you have structural problems. And we talk about when a patient, when the mother have what? When the mother have what? That can cause a problem. When the mother got
Diabetes? I can't find, I don't have.
all right. Structural problems, like when the patient have microcephaly. Like when you get the Zika virus. The mother gets the Zika virus, the baby born with a small head. Retard, well, don't say retard anymore. It's challenging. Guys, if you go by the structures, you will not be going through what we do right now. Because everything will just pop into place. We're not doing that. That's why it seems so like a lot to come. But if you go by the structure, trauma, head injury, structural, damages during the baby congenital, like the mother get Zika virus or German measles. We went through all those things. And if you do it along that path, you will not have a problem. There's a reason why I could give you guys it from, look at it that way. Vascular, we went through vascular. What with vascular? We said that the person could even get dementia. Because you get what? Vascular dementia based on the hypertension that you were just talking about. It damages the blood vessels. And you get vascular dementia. But if you try to do it the way you guys are talking this now, it's going to be overwhelming. It's going to be too much for you. You don't need to do it that way. Just do it to the structurally like how you were shown. So when you're reading now, if we're going to be talking about a patient with TBI, patient cannot make decisions. The nursing intervention is going to be different than for a patient who is having microcephaly. The nursing intervention is going to be different if the patient has meningitis that causes them to become confused. One is trauma, one is infection, one is structural. Alright guys. We went through it, and I don't know what more I can do to get you guys on board. But just remember with your CNS problems, it's always progressive and degenerative. They don't have no cure, right? It can only get worse. Right? All your CNS, degenerative. Degenerative disease means it's progressive. It only can get worse. And then with the PNS, you got some hope. Right? You can take care because remember PNS is everything apart from the brain and the spinal cord. Right? And you can work with those patients and treat them and they get, they get well. All right? I suggest make it easy yourself. Go back into those areas and study the central nervous system under those areas. And that way you could not go wrong. It's going to go into side because in that, when you did that, it talk about physiatrist. Who's a physiatrist? Is it what? What's your term? Physiatrist.
Is this what we're checking out the part?
Persons who work at rehab. And why do you think they talk about that? Why did they talk about physiatrists? In fact, they put all of these professionals they talk about on the CNS. They put the psychiatrists, they put the what? The psychologists, they put the physiatrists, they put all these people under the CNS. Why? And that's why my first question, how does the CNS impact upon psychiatry? And now that's how you roll, how is going to be your nursing management? When we talk about postpartum what? Psychosis, right? And how did we differentiate postpartum psychosis from, let's say, a person with depression, postpartum depression, or baby blues? How did we differentiate that?
One is psych, the other one.
What do you mean by one is psych?
That's when the mother having a problem.
One may wanna
No, when the mother having depression.
self-harm.
There's baby
It
blue.
could be self-harm or harming the baby.
No.
There's depression.
You guys are on the, you're trying to explain, which is good. But you're not getting to the gist of it. To make the difference, what's the difference between them? You're saying one saying suicide, one saying this. But what's the gist? What's the main thing that you can tell the difference?
I did say one is psych, one is psych, one is.
You will not use the word psych. I'm not looking for the
Baby
psych.
blue was nothing.
We know it's a psychiatric problem. So what? We just talk about it. Postpartum psychosis. What's the difference? Baby blues. How can you tell the difference? That's the question. How can you tell the difference between postpartum psychosis and baby blues or thing?
Baby blues is like for about few weeks.
Guys, one basic thing you got to remember. Any person who has psychosis, from the moment you hear psychosis,
Mental
it means this
illness.
person has lost touch with reality. And this is a person who's now going to hear voices. This is a person who's going to see things. Why is a person with baby blues and don't got that type of nonsense happening? Because they're not psychotic. And this now is going to bring you to the medications which you as a nurse should be giving on the doctor's orders. And when you give these medications, this is how we start talking about tardive dyskinesia. Guys, let's move on to another system. Because I give you guys the way to do it and not doing it. You gotta move on. Alright, let's go to the heart. Some person said they were having problems with the cardiovascular system. So let's look at it and see what we can take care of that. Because some person saying they're having some issues. Alright? Alright, about 5 or 6 persons put down on the list there that they're having problems understanding the pathophysiology for the heart. Now, which is a cardiovascular system. And just like how we look at it and we say cardiovascular system, right? We want to break it down the same way when we're doing the pathophysiology. Cardio is the heart. Vascular
Vessels.
is the blood vessels.
Blood vessels.
And the components will be your cells. Okay? Now, let's look at the heart first. So the heart is this big pump that's pumping blood for us, right? And that's the main function of the heart is to what? Pump blood. And the reason it's pumping blood is to do what? What's the rationale for pumping the blood? So it concerns oxygen and nutrition around the body, right?
Yeah.
So if that heart don't pump, the body's not going to get blood supply in terms of oxygen and nutrients, and that's a problem. So the body depends on the heart. But then again, the heart could get a problem. And so when the heart get a problem, it can't function to help the rest of the body. So when we do pathophysiology, the cardiac, we're talking about disease processes affecting the heart. So let's look at our diseases that affect the heart, common diseases. And the common diseases that affect the heart are usually anginas. And when we talk about angina, we usually talk about two types, right? And those two types are there. Stable and unstable angina. So what's the difference between stable and unstable? Come on, this is discussion now. The stable angina is all right. No, you're mixing it up.
Stable angina is precipitated by activity.
I want you guys to think first before you look it up.
Okay.
Because this is a problem we have when people are not using things. What is it? Again, remember when my opening, when I started to talk, I said the heart is what? A pump. And it pumps blood all over the body. But the heart itself needs blood to function. And if the heart don't get this blood, it will start causing pain. That's the first thing it does. It will start complaining. And the way the heart complains is by having these pains. And the rationale for that is, look, if you're asking the heart to send blood around the body, when the heart needs X amount of blood itself to push that amount of blood around. But then instead of you giving this heart X amount, which is like say $500, you'll be giving the heart what? $300. So what do you think happens? If you're a worker, you're supposed to get $500 and the boss only give you $300, what are you going to do? You're going to complain, right?
Yeah.
That's exactly the heart does. You start complaining by giving you pain. And when it gives you pain, you're going to know, say you got chest pain. And the boss will say, man, I need more work to be done. You ain't doing all the work. I need more work to be done. And now, you're going to complain more because the boss is what? Trying for you to do more work, but he give you no more money. So you're going to complain more bad now, right? You want to call you rep, you want to do all kind of stuff. The same thing happens with your heart. When you normally you're working, you're weeding the ground or you're doing something, the pain comes on, right? Because of the activity. And if you slow down somebody and I'm going to rest, the pain goes away because the heart don't got to walk like that any longer. But if you start going now and start to pick up pains and lifting and doing that kind of stuff, the pain comes back on. So for stable angina, it means that whenever you're involved in activities, you will get the pain because you're asking the heart to work but not supplying the heart with enough blood. So if you stop asking the heart to work extra, the heart ain't got a problem. It's going to function normally, right? But the moment you start doing something, the pain's going to come on. And we got to move away from that carbon medication. Rest. Rest. Now, she mentioned medications. And normally when people get problems with the heart, they give them glycerol trinitrate, sublingual medication. So look up glycerol trinitrate, please.
Glycerol trinitrate.
Yes, somebody read glycerol trinitrate. You gotta speak louder than that. Nitrate.
Nitrates are used in general as a chest pain by knocking out blood gets to the muscle of the heart. This usually happens because the arteries are become hardened and
No, read more. Anybody else have anything else to add to glycerol trinitrate? That's all you guys see associated with angina. You need to see more. You need to see more. Go down into glycerol pharmaceuticals, glycerol trinitrate.
It's also known as nitroglycerin, and that's why. Nitroglycerin.
Guys, settle down, please. Guys, settle down, please. This person just come and have a seat. Any more information? Glycerol trinitrate. What are the adverse effects? What, when should you use it? Those are the things you're looking for.
It says here that, but it doesn't answer those questions. It just says here that nitroglycerin is a vasodilating. It's vasodilating and can relieve coronary pain. The vasodilating effects decreases the venous return and arterial blood pressure, thereby reducing oxygen consumption. It is most effective if given 4 hours of symptoms onset.
It's given within 4 hours.
It says here it is most effective is given within 4 hours of symptoms of onset. It's used to treat for the treatment of angina by causing the release of nitric oxide in the vascular smooth muscle of the target tissue.
So here the acute effect of hypotrypsin is mainly the reduction of systolic blood pressure
All right, you know it is a vasodilator, right? Now, look for nursing management for the administration of nitroglycerin or visceral trinitrate, anyone you want to.
Nursing management for I got some stuff here. It says that instruct the patients to make sure. Okay, this is about
Ask the question of each end.
sublingual nitroglycerin.
It's always given sublingually. It's always given on the tongue.
Okay, so it says instruct the patients to make sure the mouth is moist, the tongue is still, and the saliva is not swallowed until the nitroglycerin tablet dissolves. If the pain is severe, the patient can crush the tablet between the teeth to hasten sublingual absorption. There's more. Continue.
Yeah, I'm waiting. What
Advise the patient to carry the medication at all times as a precaution. However, because nitroglycerin is very unstable, it should be carried securely in its original container, a capped dark glass bottle. Tablets should never be removed and stored in metal or plastic pill boxes. Explain that nitroglycerin is volatile and is inactive by heat, moisture, air, light, and time. Instruct the patient to renew the nitroglycerin supply every six months. Inform the patient that the medication should be taken in anticipation of any activity that may produce pain. Because nitroglycerin increases tolerance for exercise and stress when taken prophylactically. For example, before angina-producing activities such as exercise, stair climbing, or sexual
Can you
intercourse.
go back in that prophylactically, please?
Because nitroglycerin increases the tolerance for exercise and stress when taken prophylactically. For example, before angina-producing activities such as exercise, stair climbing, or sexual intercourse. It is best taken before pain develops. Recommend that the patient notes how long it takes for the nitroglycerin to relieve the discomfort. Advise the patient that if pain persists after taking a sublingual tablet at 5-minute intervals, emergency medical service should be called. Discuss possible side effects of nitroglycerin, including flushing, throbbing headache, hypotension, and tachycardia. And advise the patient to sit down for a few minutes when taking nitroglycerin to avoid hypotension and syncope.
Okay. What I want to hear is that when you use glyceryl trinitrate, because it is a vasodilator, it can cause hypotension. And remember we went through hypotension? We went through all the things that could happen when you're standing, sitting to standing, and lying to standing. We did all that when we did the blood pressure clinicals. People will take it and they will fall down. They will take it and they will fall down, and then you're going to think that they get a heart attack. You got no heart attack. You have caused hypotension. And that's the thing you're looking at. A lot of people will, if they before they go into a certain type of activities, they'll try to take these medications. The prophylactic.
It says here, there's the
But
medication.
use a nurse, because most of the times they'll be having this when they're home, not in the hospital. So you have to be teaching these persons, patient teaching especially, about what is hypotension, or what are the signs and symptoms, or what can possibly happen to them. It's not just going to be having chest pain, but they could end up on the ground. Right, moving on. So you have stable, and then you have unstable. And for the unstable, they have chest pains again also. But there's a difference in the physiology. One is a decrease in blood supply due to the development of atherosclerosis or arteriosclerosis, whilst the other, you can actually have a plaque that closes off and opens because it kind of partially breaks off in the lumen of the blood vessel. So sometimes it's blocking, sometimes it's not. Now for your understanding, just go stable versus unstable angina. Basically, what is the difference between the two? Pardon, can you read?
Stable angina is when you get angina symptoms during moderate physical activity, or when you are pushing yourself physically. These symptoms go away with rest and or medication. Unstable angina is when you get angina symptoms while doing very little or resting.
Now look at the diagram of a blood vessel that shows stable and the diagram that shows unstable. guys look at the image? You will see what the images look like. It's a stable and an unstable. So just now you heard it say that with the unstable is due to when you're having activities, you have a chest pain. But with the unstable, you don't have to have the activities to get a chest pain. And that comes to what I was just telling you. It can be partially blocked, and then it can be blocked, and then it can snap, and then it becomes partially again, and then it becomes blocked. So when it's blocked, you don't have to do no activities. You'll get a chest pain because no blood's going through.
Right.
But then it can change back again, they open up back again.
So you can get.
So there are basically two types, and you know that the two types are the stable and unstable angina. And that tells you that something is going to happen. Now both the stable and unstable come under the categories of CAD, coronary artery disease. So if CAD means coronary artery disease, it means that something is happening to your coronary arteries that's creating the problems. The coronary arteries are responsible for supplying the heart with blood. So when these coronary arteries have a problem, the heart is not going to get the blood supply. So I've given you 3 words actually: plaque, atherosclerosis, and arteriosclerosis, and those all creates blockage. And this blockage can be related to also your food intake and your body itself in the production of those lipids. So with the cholesterol, you look at 2. HDL and the LDL. You have a tendency to say the HDL is good, the LDL is a problem. And basically when you're eating your food, that probably get a macronutrition on what happening. You want to be eating unsaturated fats, not saturated fats. So let's first look at the lipids. Let's look at HDL. Let's see what's good for you first. So look at HDL. The high densities, anyone,
High density lipoprotein is one of the 5 major groups of lipoproteins. Lipoproteins are complex particles composed of multiple proteins which transports all fat molecules around the body within the water outside cells. They are typically composed of 80 to 100 proteins per particles. HDL particles enlarge while circulating in the blood, aggregating more fat molecules and transporting up to 100 of fat molecules per particle.
Come on, break it down to the simplest the person will understand. All I know personally here now is HDL is good for you, but why? That's what we want to know. Why is it good for you? What makes it good for you? Because remember, this is where your patient teaching is coming, and this is your understanding when you're going to be writing an exam. Why is it good? Why are drugs not good? You have high density, you have low density. So why is the high density good and low density is bad? What absorbs the cholesterol and takes it to the So it's called the good one, right? Now let's read the LDL now.
Mix of multiple bodies cholesterol. Level of LDL cholesterol raise your risk for heart disease and stroke.
So these HDLs good for you. And the LDLs are bad for you. But that means so you have more LDLs around. So the person has a lot of cholesterol, what is called hypercholesterolemia, right? So let's look up for hypercholesterolemia.
Hypercholesterolemia.
Let's just put high cholesterol levels. Let's just bring it up. Let's say something about
Hypercholesterolemia, also called high cholesterol, is the presence of high levels of cholesterol in the blood. It is a form of hyperlipidemia, high levels of lipid in the blood. Hyperlipoproteinemia. Okay.
all right, this is going back to the same levels that you just spoke about, right? The HDL, the LDL. All right, so you have hyperlipidemia or hypercholesterolemia. It's just about the same thing. So now you know that it could be present in food, right? And it could be made by the body. Now, the doctor is the one who has to take care of it, in the sense of pharmaceuticals. So for the pharmaceuticals, he's going to order statins. So let's look up your statins. Let's put statins. So just put in statins, and then it's going to give you your Lipitor and your Crestor and all these different tools. Put it down, please.
Statins, also known as HMG co-reductase inhibitors, are a class of lipid-lowering medications that reduce illness and mortalities in those who are at high risk of cardiovascular disease. They are the most common cholesterol-lowering drugs.
So now you have these, you administer it. But you're just the second person here, you administer the doctor's order. So what are you looking for? What will be, you know what's the desired effect? To lower the levels, right? So you ask the question now, what is the normal cholesterol level, male and female?
Under 200. Under 200.
Please look it up, man. I know you know it. Don't show off now and say you don't know it. I know you know it. Let's look it up. Males and females. Alright, look it up and see for male and for female. You repeating what you say. Come on, guys, just tell me. Cholesterol levels for male, normal cholesterol male, normal cholesterol levels for female. And what's the normal range of men?
60 milligrams. Or above.
Anybody, please? Nobody find normal level?
So that is less than 40 milligram for men.
That's a 40?
Yeah.
No. Look.
Address, they said address. For men, less than-
For men around 20 and older is about 125 to 200.
Okay, all right. Some men over 20, right? 125. Now what about women?
Not it?
Nope. I think I got it.
Look, huh? This one gives you different thing. What is this?
They say women and men, 125 to 200.
Women age 20 and older,
Age
it's
20
less
and
than
older.
130.
Yeah, which is,
Less than how much?
130.
it's a 125 to 200, I think.
It's yep, 125 to 200
Yeah, and
for females 20 and above.
older, yes,
As women age 20 years old
age and
and
sex.
older, so cholesterol is less than 900 mg.
Total cholesterol for females 20 and over is 125 to 200.
To 200.
And yeah,
So you're saying that both the men and women have the same levels?
that's what it says here.
No.
.net.
One, how much for the female?
130 to 159.
This is not a reliable internet.
Everybody, look at your sources.
Everybody.
Yep.
The females have a tendency to have it lower than the men.
Oh, let's look at this one here.
Right. Okay, so you're giving this the statins to lower the cholesterol. What is the adverse effect? You know what's the effect now, right? Lower. So what is the bad effect? What can happen when you use it?
Muscle pain, increased risk of diabetes mellitus, at abnormal blood level of the liver enzymes. Additionally, they have rare but severe adverse effects, particularly muscle damage.
Let's go over the complaints, patients who are on statins. Look at it again.
Who are in statin?
Patients who are on statins, what are the adverse effects of the medication?
Pain.
List, just put list common effects of the medications, but I can't go through the list for you.
Headache, difficulty sleeping, muscle ache.
Headache, dizziness, feeling sick, feeling drawn, usually tired, physical,
Right, one of the things
digestive
that
system.
you really want to
problem,
look at
muscle pains.
is
Muscle problems.
people who are on statins, they complain a lot of pain, muscular pain, tiredness. They're all going to say, damn, you know, my muscles, I can't take. It's a very common thing. And also these statins, they can mess up your liver. But remember, the function is the liver is the one who does all the
Filtering.
breaking down the fats and multiplications and that sort of stuff. But I want you just to remember this. Anybody know who's on statins and they come and say, you know what, man, I get some bad, muscle pain and thing, I don't know, my feet tired, my knees and these things give me pain, I can't walk up the stairs. It's just a statin. It's not really, it's a statin. Alright? And sometimes you need to talk to their doctors. Because the statins, and you may change, go from one to another one, whatever it is. Right? I've known of cases where persons had to be taken off one and put on another. Or you have to lower dosage or what we said. So please, when you're doing these medications, you know, it's to lower your cholesterols. It's very important because you know the cholesterol goes up and you block it with your coronary artery, which will lead to angina. And eventually to the one that you don't want to have, which is the myocardial infarction, then known as your heart attack. Okay? When you look at your heart attack and your unstable diet, angina kind of close in the sense of one thing, is that you get a pain regardless if you are resting. You know, with the stable angina,
I couldn't find nothing on that.
you get pain if you're exercising. But with myocardial infarction, and at times when you're unstable, you don't have to be resting. I mean, you don't have to be exercising. You may be lying, sleeping, and you get the pain. Right? Because the pain is not due to you need more blood. It now means because you're exercising, you need more blood to do the exercise. It just means now that the blood has been totally cut off to that specific area. And you don't have to be doing anything. So those are the three things that go to your CV. There come out also something called ischemic heart disease. So you have your coronary artery disease. And you have the ischemic heart disease. So let's see. What is ischemic?
You said coronary heart disease?
I said we just discussed coronary artery disease, but you also have ischemic heart disease. So what is ischemic heart disease?
Is the term given to heart problem caused by narrowed heart arteries. When arteries are narrowed, less blood and oxygen reaches the heart muscle. This is also called coronary artery disease and coronary heart disease. This can ultimately lead to heart attack.
You guys follow just now what she said? What did she just said? That put everything in a nutshell.
The ischemic one become now.
Both coronary artery disease and ischemic heart disease is the same thing.
Yeah.
And ischemia, what is an ischemia?
Narrowing.
Look for the word ischemia.
Inadequate blood supply.
There you go. That's all you need to know. Inadequate blood supply. In your coronary artery disease, inadequate blood supply. Ischemic heart disease, inadequate blood supply. What is causing inadequate blood supply? The plaques. The hypercholesteremia, hyperlipidemia, right? The
Inadequate
deposition
blood
of plaques.
supply.
And where is the deposition of plaques taking place?
In the vessel, the blood vessel.
In the lumen of your blood vessel. In the lumen of your
Of your
blood
blood
vessel.
vessel.
It becomes partially blocked, and that's when you get angina. And it becomes totally blocked, you get
Unstable.
infarction.
Heart attack.
An infarction is when you don't have any blood going to an area. So once you have a blockage, no blood can go beyond. And when no blood goes beyond, it means that part is not getting any oxygen nor any nutrients. And any area that don't get oxygen nor nutrients is known as an infarct. And because the heart is a muscular pump, and it's the muscles of the heart, which is called your cardiac muscles, that pumps the blood, this ischemia happens in the muscles of your heart. And the muscles of your heart are your myocardium. Remember, you have your pericardium or epicardium, your myocardium, and then your endocardium? The muscles is your myo. So therefore, if you have this infarct in the muscles, you'll have myocardial infarction. Meaning the muscle is dying. And so therefore, it's like the pump will break down because it's not working. The muscles that become infarct will start to die and become what? Necrotic. And then we find like words of necrosis will come in. Look for infarct. So look at an image of an infarct. We did this before, so it's just putting it up back. Look for an image of the infarct. Definition, and then look at the image.
There's no localized area of the tissue is inferior to black. You got a better definition.
Infarction?
Infarct.
Infarct and infarction is the same thing. A small localized area of dead tissue resulting from failure of blood supply. Same definition.
Process and it is.
Look at the cross section of your heart, and it shows you where it infarct. Remember, infarct is only going to be that part of the heart. It's not the whole heart is going to have an infarct. It's just that part of the heart. Remember, the coronary artery has what? Arterial branches. Do you guys see a cross section?
Yeah.
An image?
Yes.
All right.
You see
Cross section of what you said?
the dark part.
All right. I just wanted to know that until now you've looked at two categories of pharmaceuticals. You look at a vasodilator, and you look at No. What's the other name? Pharmacology or pharmaceutical USA? Vasodilator and
Vasoconstrictor.
was it? Did you look at the statins? No. And the statins are vasodilators, right? No.
The nitroglycerin.
Statins are not vasodilators. Only we look at the name. You're not the nitroglycerin or glyceryl trinitrate, which is a vasodilator. Open up it so the blood can go inside. Open up the blood vessel. Then we look at anti-hypertensive cholesterol. We go with the statins to reduce the cholesterol. It's two different pharmaceutical or pharmacology medications. Keep track of what you're talking about.
They lower the LDL,
In your blood.
LDL
That
level.
is statin. Lowering the cholesterol. All you need to remember.
The primary
We
use
went through the side effects and the big problems and the patient teaching.
muscle
But you
pain.
must understand the different categories. Now let's go straight to CHF. Congested heart failure. So the heart is a pump,
Congestive heart failure.
but now the pump is not working effectively. It didn't stop working, it still continues to work. Somebody with congestive heart failure.
Something.
Congestive heart failure is a set of manifestation caused by the failure of the heart's function as a pump, supporting the blood flow through the body. Its sign and symptoms results from a structural and or functional abnormality of the heart that disrupts its filling with blood or its ejecting of it during each heartbeat. Signs and symptoms of heart failure commonly include shortness of breath, excessive tiredness, and leg swelling. The shortness of breath is usually worse with exercise or while lying down, and may wake the person at night. A limited ability to exercise is also a common feature. Chest pain, including angina, does not typically occur due to heart failure.
Difficulty chest pain going to court. Why don't you chest pain going to court? Why don't you chest pain going to court? The heart is already in failure, you're not doing anything, you're not really, as you just stated, no exercises, no. So just lie down and you get in sharpness of breath. The heart is not going through what you normally go through the angina and the myocardium because you have some structural problems going on there.
It's pain.
Remember, there's structural problems with your heart, there's defects in your heart that release the CHF. And one of the things I remember with the person with CHF, they're always very anxious because the fear is that they're gonna hit the bottom. And these are the patients who are going to be the ones who always will be the call bell, just because they want persons to be there. And after a while, the staff will get just disgusted with them. Just keep ringing the bell, ringing the bell, ring, go, you don't really know where it is. But it's just anxiety, and they go through anxiety. It's something that these people need to be kept calm. Now look at some of the structural problems that can happen in the heart. Let's look at a pulmonary stenosis or pulmonary stricture.
Pulmonary stenosis.
The pulmonary artery.
You want me to look up pulmonary stenosis?
Pulmonary artery stenosis, pulmonary stenosis, right?
Pulmonary stenosis is a dynamic or fixed obstruction of flow from the right ventricle of the heart to the pulmonary artery. It is usually first diagnosed in childhood.
When you have that, it means that the pressure will back up. The pressure will back up. So the right side is your heart. And on the right side of your heart, there's a serious problem. Now let's look at these same problems that occur between the heart. We call it shunt now. We're talking about a left to right shunt. VSE, but in VSE, ventricular septal defect. Let's go to left to right shunt.
Ventricular septal defects.
Let's put in left to right shunt.
Ventricular septal defect is a defect in the ventricular septum, the wall dividing the left and right ventricles of the heart. The extent of the opening may vary from pin size to complete absence of the ventricular septum, creating one common ventricle. The ventriculum septum consists of an inferior muscular and superior membranous portion and is extensively innervated with conducting cardiomyocytes. I don't know what that means.
Look for the left to right shunt. But for heart, left to right shunt.
A left to right shunt is a cardiac shunt which allows blood to flow from the right heart to the left heart. This terminology is used both for abnormal states in humans and for normal physiological shunts in reptiles.
No, we're talking humans.
So we're talking about humans.
Look at the image of the left to right shunt. Look at the heart. Can you see the image?
Sure.
You guys see an image. Do a cross section so you can see a diagram of a left to right shunt. You guys see that?
Nope.
The diagram that Mr. has, it has the blue and red. So if the blue, you know, it's deoxygenated blood, right? And the red will be the oxygenated blood. And you see the oxygenated blood just going over back into there,
So the red.
over to the deoxygenated. Normally the patient don't really shut it up because all that's going to happen is the blood just go back to the what?
The lungs.
To the lungs and come down back, and so it's not much. Let's look and see cause of left to right shunt. Cause of left to right.
Cause of left to right shunt.
Left to right shunts typically occur as a result of a atrial septal defect, a ventricular septal defect.
Okay, full stop. It typically caused by what? A septal defect. Remember I just said to look at VSD? Right? Ventricular septal defect. So you have that defect. And blood, why do you think it's going to go left to right?
Something is open.
It's going to go left to right because the left ventricles are more powerful. The left side of the heart is more powerful than the
Right
right
side.
side. Because the left side got to push it around the what? The body systemic circulation, while the right side is just the pulmonary circulation. So if there, the pressure on the left side is going to be higher than the pressure on the right side. And because it's going from oxygenated to deoxygenated, you don't really see much problem. Now let's swing the rock. Go from right to left shunt. So what do you have to the right to left? Anybody read? Left, right side of the heart. Right heart. Well, you get two hearts. Right side to the left side. Alright? Now, look at the image. Look at the image. Again, look at the color. You guys seen the image? Come on, you gotta look at that image, you know, how many impressions are you? This is how you're gonna remember this. Left to right and right to left, Sean. the ventricular atrial septal defects, the muscular contractions, all have to come into play. And we kind of like looking in this, the CHF, the heart kind of turns a pump. You guys see the directions? Are you guys finding it? You're not finding it. Look for cause of right to left shunt. What caused right to left shunt? Got heart shunt, cardiac shunt before it tells you something else.
Systematic circulation.
Right. You guys got it when you did the feature. What's next? What else? What else did it tell you?
Outside of that, not really have condition, circulation of the heart condition with dominant activity brain, life condition,
Pulmonary.
arterial
So the pulmonary artery can have a malformation. Remember you just talked about the pulmonary artery? I would say pulmonary what? Stenosis? Remember you just talked about that? So you got a problem there. That means that what? The pressure is going to push over to there, build up on the right side and push the blood over into the left side. And now you're going to have a problem. And why do you think you're going to have a problem? Because all of that deoxygenated blood getting pushed into the left side and now it's being pushed around the body. So the body's going to be without the oxygen that's normally filled. Are you guys with it? Did people understand this, guys? When you see right to left shunt and left to right shunt, you know they gotta have a hole in the heart.
The left one.
You gotta have it on the ventricles or the atrium. When we did the foramen ovale with the babies, they were fetus. Was it with the artery, right? Then we did the tetralogy of Fallot, which is the 4 points, right? Include the VSDs and what have you there. So this is now to the dog stage 2. You get older, you will get some problems. Now, when you start talking about blue babies, and not baby blues. Baby blues is when the mother's what? Depressed. But now we're talking about blue babies. And blue baby is going to refer you to what? Blue babies. Yes, of course, absolutely. You're right. Oxygen. What else? What does you need to know? Come on, look at the blue babies. It's a common layman's term. You guys also blue babies.
Reduction of oxygenated blood.
Cyanosis.
Cyanosis.
It's all good, cyanosis. You cut down the oxygen, you got cyanosis. Alright, so you did the right to left shunt and Just to write to the vanilla date. So when you read now, you understand what you're reading. And you understand how pressure plays a part. You understand that heart pushes the blood out due to systemic circulation from your left ventricle. So we know that there's something you have to know, which is the amount of blood that comes out from the heart. And when the blood is coming out from the heart, there's a term used for the amount of blood coming out. So what terms are we using? What term do we use for the amount of blood that comes out? From the left ventricle
Well,
into
look it
the
up
aorta.
before I say anything. Stroke volume.
That's what ejection fraction is.
Stroke volume.
Eject, to push out, right? So let's look at ejection fraction.
An ejection fraction is the volumetric fraction or portion of the total of fluid, usually blood, ejected from a chamber, usually the heart, with each contraction or heartbeat. Thus understood, ejection fraction may be used to measure the fluid of any viscosity discharged from a hollow organ to another.
We just look at the heart. So
Okay,
what is
from
the
the heart.
ejection fraction of the human, of the man or the woman?
Why wasn't it the stroke volume then? Because it's the same definition. It says here stroke volume is the volume of blood pumped from the left ventricle per beat.
I want you guys to say the ejection fraction. Okay, stroke volume, very simple. Two ejection fraction.
Okay.
What is the percentage? With each heartbeat? Normal?
50 to 75.
We mentioned 50 to 70%, right? So when you look and they don't normally do this, when you go and your doctor sends you for these blood tests, we look at your ejection fraction to see if the heart is what? Pushing out
Pushing enough blood.
So this brings you back to when you have your what? The heart function as it pumps to your CHF, right? Remember, with CHF they have what? Failure for the heart to function as a pump. How are you going to check it? You look at the ejection fraction. And you'll see that it's not pushing out enough blood. You guys with me? Okay. But the heart itself is not going to push anything unless it gets commands. Unless it gets commands to do things. And we know the CNS have control over both your voluntary and involuntary.
Involuntary.
That is your striatic and your smooth muscles, right? So the heart is a cardiac muscle. And it is striated, but it has the qualities of this smooth muscle that you don't have any control. So something has to ensure that the heart maintains a rhythm. And what is responsible for that?
Pacemaker. The pacemaker?
Right. So we call it the electroconduction system. And the pacemaker, and why they call it pacemaker? Because it initiates everything. Right? So the pacemaker of the heart is usually, or not usually, is the SA node, the sinusoidal node. And what does the sinusoidal node do? Send signals where? To the right and the left. To the right and left.
Sinoatrial node.
Left and right to the atrial, right? And that causes contraction. And then it continues on to your, from the atrium goes to your AV node. Because you gotta slow down, right? So that you give the time the ventricles to contract, right? And from the AV nodes, it goes down to your bundles of His, and then it goes to your Purkinje fibers. But the thing is, when they look at these, the radiologists and guys look at these images and what have you, they'll talk about conditions that is affecting the patient. Now, you know about pacemakers being put in, right? Because the heart is what? It's not functioning properly. So you have what? Irregular heartbeats, right? That's how we know it's on front. Irregular heartbeats, what else? Irregular, missed, or skip heartbeats. So when this occurs, they call them arrhythmias, isn't that it? Arrhythmias. So the patient having arrhythmias. Sometimes it can be very, very fast, right? And you can get like a flutter, which is a big problem. Now, just now we covered left to right and right to left shunt. Now we know the bundles of His, right? We got a right side and got a left. Now look for me, left bundle branch block.
Left bundle branch block is a cardiac condition abnormality seen on the electrocardiogram. In this condition, activation of the left ventricle of the heart is delayed, which causes the left ventricle to contract later than the right ventricle.
It's simple, right? Remember? Sino, AV, bundle branch, left and right. So if you have a problem going to the left side bundle branch, you're going to have a problem with the contraction, because it's all it's doing is sending this electrical impulses, these messages to pump, to contract. And if it don't reach because of the problem with the pathway, you'll get a left bundle branch. Now go over to right bundle branch and see what it says.
Right bundle branch block. A right bundle branch block is a heart block in the right bundle branch of the electrical conduction system. During a right bundle branch block, the right ventricle is not directly activated by impulses traveling through the right bundle branch. The left ventricle, however, is still normally activated by the left bundle branch. These impulses are then able to travel through the myocardium of the left ventricle to the right ventricle and depolarize the right ventricle this way. As conduction through the myocardium is slower than conduction through the bundle of His Purkinje fiber, the QRX complex is seen to be widened.
Alright, so basically, your SA sends it down to your left and right auricles, then it goes to your AVs, right, to your bundles of His, bundles of his, and this is inside of the ventricles. So this that's going to the bundles of his get blocked on the left side, which is on this side here, meaning the message can't go down to the ventricles as it should. So the ventricle is not going to contract as it should. Same thing happened over here. If it happens over on the right side, the message is not going through. What's going to happen? It's not going to contract as it should. And remember, the heart has to what? Contract
To send the
to
blood.
push the blood. And this is where you must understand impulses. When you did the CNS, you know that the brain and the spinal cord makes up your CNS, right? And you know about your sensory and your motor. Well, your SA node is like your motor. Your SO node sends the messages. But if they have a blockage along the way, it's not going to go. And it's going to be a problem. It's just like your brain send a message down, move your foot, but you had a problem, so the message can't go. Same thing happens with the heart. And that's why now you have to take over and do sometimes surgeries. Because the problem here is not the SA node. The problem is the blockage of the impulse at the level of the bundle branch. Okay? No, pacemaker send the message. Pacemaker sending the message, but it's the message is not going as it should. Something is causing problems along the way.
It's a blockage.
It's when the pacemaker have a problem now, and at this level here, SA node, sino-auricular, atrial fibrillation. Look up the atrial fibrillation. That's the biggest problem in people. That's the biggest concern you can have, atrial fibrillation.
Atrial fibrillation is an abnormal heart rhythm characterized by rapid and irregular beating of the atrial chamber of the heart. It often begins as short periods of abnormal beating, which becomes longer or continuous over time. It may also start as other forms of arrhythmias such as atrial flutter that then transform into atrial fibrillations. Episodes can be asymptomatic. Symptomatic episode may involve heart palpitation, fainting, lightheadedness, shortness of breath, or chest pain.
You know, sometimes people say, "Mom, my heart fluttering."
Heart failure, dilation, stroke.
That's a good way to describe atrial fibrillation. When you're saying, "Oh my God, my heart is just beating fast," and that's atrial fibrillation. And that's not a good thing. It's very, very bad. Very, very bad. Okay? AFib is not something you want to get. Because we're going to pursue the use of pacemakers. Now, if the heart has to work extra hard because of some of these things that's going on in the heart, it will cause the heart to get what?
Bigger,
Enlarged.
bigger, enlarged.
So an enlarged heart is known as
Cardiomegaly.
cardiomegaly. But if a heart is big, it's supposed to work better, isn't it so? More muscular. Why is it? Why you
Yes,
say
it
no? You
is.
got more muscles. So why you say no?
Thank you.
You have what? The muscles become thick.
This week.
But the thicker don't mean stronger? I thought when you got thick muscles, the stronger muscles, than if you got thin muscles. So let's look at cardiomegaly quickly.
Cardiomegaly. Cardiomegaly is a medical condition in which the heart is enlarged. As such, it is more commonly referred to simply as having an enlarged heart. It is usually the result of underlying conditions that makes the heart work harder, such as obesity, heart valve disease, high blood pressure, and coronary artery disease. Cardiomyopathy is also associated with cardiomegaly.
All right. So this big heart, you may get the muscles enlarged, but they're working less. They're working less. So if before you so 1 pump ejection fraction, 50 to 70, 1 pump maybe 30, maybe 40. It's not functioning the way it should. So cardiomegaly is the result of all things we just talked about, right? CD, IHD, all these things can cause it. The blockages, anything that causes the heart to work harder. It's like going to the gym. If you have problems or line problems that cause the heart to work harder, the heart is going to get more muscular, but the muscle is going to work. So the function of what the heart has to do with is the pump. You guys with this?
So I shouldn't go to the gym then.
Yeah. Say again?
So I shouldn't go to the gym then.
You come with your heart. You talk with you. Come with your heart. If you don't go to the gym, then you're going to have a problem. And summer coming up, everybody want to wear those fancy clothes, right? So you go to the gym. Both men and women. I want to go to the gym.
I'm going to DR.
I want to go to the DR. Good. That's the thing. Go to DR, we not worry about nothing. Oh, by the way, guys, this weekend we're not going to be having any what we talked about. Stay with me, stay with me, stay with me. Stay with me. The reason being, I consider we're still going to have it, but we're going to have it to the last Saturday of the month, which is the closing off of the classes. So it'll be more of a closing off, something, closing off, what else? The nurses week, any nurses week, we're going to just send back a little. And sorry, I was trying to see, you know, you guys come to the Wednesday, Thursday classes and 1 or 2 courses. You would have known, I told courses at that time, and I did exactly the same. I know people would go on the test there. I don't think you would test. But I said don't go with it. No, I did. It's good, because we got today's morning, we still got about 10 minutes. It's going to be better, it's going to be much better, because there's, the last Saturday is the 28th. So you guys can do a lot more. a lot more for that because we're going to make it more something that is really memorable. Because I know, what time you guys are going to Florida? No, what date is it within Florida? The 4th? That's the same week, correct?
That's the next week.
Next Saturday.
Okay, so at least you'll get a party before. The real party.
Before and after.
Huh? No, this is me doing the thing. This has nothing to do, because I don't know how many courses are going down, but the classes is going to be doing.
We not know.
I don't know. The Saturday, that Saturday, you guys never come to Saturday class, right? No. Because I usually have the Saturday class. The Saturday class is big. It's what you're saying, it's just the day and how I've set it up is quite different from you guys. It's quite different. So I don't want that to change. I don't want to, set something up to be by example. I've never stayed away from any person. So that there is other standards to some other, I don't.
So you don't want to do this.
I would love to be there with you guys.
The way you talk now.
No, I would have to talk to Stanley because when we had the last school graduation in here in New York, it was Sunday. Didn't have no classes on Sunday, so it might just be the same thing there, but I don't know. I would love to be there. Cause I'm gonna get a room with 2 beds. One is a bed for me to sleep on, the other bed is for me to sleep on. I'm just bugging you guys, don't worry. Yeah, so I'm sorry if you guys really did go and make some arrangements. I'm really sorry. But I'm asking if you can just because I bought it in Kent and they're not gonna come in Kent. No. The last time I built it, I bought things, I built it myself. But this time I said, you'll completely screwing and knocking, and so this time I just saw the reaction and it too much. 2 days and still, to break it down, it took me another 2 days, so I did with that. Alright, somebody's over the bathroom. Guys, I hope you guys are following the sequence. And that's it, that's the concern I'm having in the class, is that you guys are not following the sequence. Last week I gave you John Hopkins' way of doing it, and I think it's a beautiful way of studying. Right? Root is based on the different things, trauma, infection, structural, functional. And when you do it that way, you kind of lost. And the beautiful thing about it, it takes you into so many other diseases. It takes you into rehab. It takes you to physio, the psychiatrist, and what it does. What rehab, what OT will do for the patients who have problems, whether it be progressive or not, degenerative diseases. What PT will do. What's the function of the speech therapist? All of these will come into play if you study that way. Instead of jumping from that one to that one to do this follow sequence. all the secrets, and you're good. All right? All right. You guys heard what I said, right? Until next 28th. We want to have a big bash.
Is that Memorial Day? It's gonna be Memorial Day weekend?
It's a what?
Memorial Day.
Memorial Day
Memorial
weekend.
Day weekend?
Yeah.
I'm not gonna be here.
She go to Seaview Park.
You have
That's
enough
good.
program.
She do it in Seaview Park.
And where?
Seaview Park. It's
If
right
you would
there.
go there and hold a space, I would love to have it out in CP Park.
Yeah.
You can't hold
If somebody
Huh?
would early,
You can't hold the space?
if somebody
You don't have- you
would
don't have-
early and hold a spot,
We could.
Yeah, I live
We
right
live
there.
in Canarsie.
that'd be good.
You can't live right there.
I live right there.
That would be good.
You know?
CP Park,
So we can't turn up the music, right?
We wanna go in
the only
and
thing
then
we will get is
we're
a
gonna
lot of
have
parking.
all our food
Parking
hot.
gonna be a BITC.
Have it
Take your part.
What about you?
All right, guys, we got time. You can think about it and put your thoughts together. So we will do what we have to do at that time. All right.
Oh, that's on Neely. You didn't give one to Neely?
And then I'm going to be talking to certain persons because I want certain persons to do certain things.
Sandra.
So I will talk to you.
Needly.
I can.
Sandra, you
No.
not to get up.
Just this one.
All right, guys, let's move on.
I'll open it.
So, until now, we kind of look at some of the diseases that affect the cardiac system because there's a few persons put on that list
What?
that they did not understand what the cardiovascular system is all about. I do hope that while what we'll be going through, that persons who are educated or having problems with it will get a better understanding. Right? You have other infectious diseases that affect the heart, such as pericarditis, myocarditis, and endocarditis. It's basically you take the 3 layers of the heart
Oh my
and you
God,
put
pale.
itis at the end of it and you get an infection. But the thing is now you gotta understand is what causes these infections. You can't just say pericarditis is infection of the outermost layer of the heart. You can't just, you know, because one of them that you come across more often than the others is endocarditis. Endocarditis is much more
Prevalence.
frequent than the others. Okay? So, you got to go into those different sections of the heart, just like when you do the meninges of the brains. You go through the layers, you go through the same layers of the heart. Is that understood, guys? You did the blood flow, you did electrical conduction, you had an overview. Please go over it. Please go for it.
We should get it this one.
Alright?
How you say that? Oh, I should put a test on WhatsApp.
Okay. Now, these blood vessels that you have, you kind of look at 3 blood vessels, right? You look at the arteries, the veins, and the capillaries, and we all know what the structures are and how these blood vessels are affected. We know that the arteries carry your oxygenated blood, except your pulmonary artery. And your veins carry your deoxygenated blood, except your
Pulmonary vein.
Right? Then you have the capillaries. And what you know about the capillaries? is that at the level of capillaries, all gas exchange and nutrients take place. Not at the level of the arteries, not at the level of the ventricles, but at the level of your capillaries. So wherever it goes, into the alveoli of the lungs, the heart itself, the kidneys, it's always at the level of the capillaries, all the exchanges take place. So, we have different types of problems that can affect these blood vessels. We kind of talked somewhat about the arteries on the top of there, coronary artery disease and ischemic heart disease. They're all arteries, right? But that was the arteries of the heart, the coronary artery. But you have arteries that go to other parts of the body. And they too can become affected. You have blood vessels that moves from your main blood vessels into smaller blood vessels, right? And when things like that happen, you can get conditions known as peripheral vascular diseases, right? PVD. Meaning that the blood vessels down in those areas, the peripheries, just like your peripheral nervous system, peripheral vascular. Same thing. The blood vessels that go to your extremities. You can have problems in those blood vessels. Well, one of the things I want you to know, because we focus a lot upon the arteries, and the arteries bring blood and bring nutrients. But we got to focus a lot on our veins. And we know that when a vein is infected, it's called a phlebitis. Some of you have gone through botany, right? And we know you take the blood out of your veins. And you need to know the veins well, especially your superior and inferior vena cavas. It brings the blood flow from the upper and lower part of the body. So you must understand how the blood returns to the heart. What is responsible for making that blood move? What is responsible for making that blood move back to the heart? We know how it gets around the body from the heart. We know it's the heart pushing it. But how does it get back now to the heart? From the what? No. I just said that the arteries are pushed by the heart. That's why it gets in blood pressure, right? But now I'm asking you, how does the blood get back to the heart?
Peristalsis. Peristalsis
What's
I think that
peristalsis?
they are
from the veins upwards.
Look up the word peristalsis, please.
Peristalsis.
Tony,
What you tell the baby?
I
so
want,
you tell her a joke
I want-
and she hear it, and
I want to-
you laugh.
I want to laugh too, Sonny. I want to laugh too.
Sony, you crack up on your own joke. She didn't hear me. You gotta let her hear it too. Anyway, come on, peristalsis. What?
Peristalsis, a radical symmetrical contraction and relaxation of muscles that propagates in a wave down a tube in a retrograde direction. Peristalsis is progression of coordinated contraction of involuntary circular muscles, which is preceded by a simultaneous contraction of a longitudinal muscle and relaxation of the circular muscle in the lining of the guts.
Not in the digestive system.
Make sense, Mr. Lee?
Yes.
Yeah.
You have some muscular contractions that will facilitate the movement of blood in your veins.
Try it today.
And these muscular contractions are the ones responsible for pushing the blood up back to your heart. And that is why your veins have valves, so that the blood is not going to do what? Flow back.
Valve.
But what I want you to associate this flow back to the heart, I want you to associate it with your lymphatic system. Why do you think I want to associate it with the lymphatic system? Why do you want to associate the venous return with the lymphatic system?
How is venous return related to the lymphatic system?
We lost some fluid and the lymphatic system picked up and back into the
At the level, let me just go over the capillaries. We said the level of capillaries we have. Exchanges all exchanges capillaries, right? By the level of capillaries you have fluids being lost. A lot of fluids. And this fluid have to be put back into the blood. That's where the lymphatic comes in. The lymphatic picks up the fluid and it puts it back into the blood. And then you go to the top of the subclavian vein, where you have the lowest point of pressure. So they can flow into it and not have any resistance. Because if these fluids are not picked up and put back into the system, you're going to have edema. You have swelling, pedal edema, anasarca, generalized edema. So your lymphatic system works very closely with your cardiovascular system. Very, very closely. Because all that fluid that is being lost, which is your plasma, has to be put back into the blood as lymph. Before that puts back into the blood, the lymphatic system goes a step forward. It has nodes to filter it, to ensure that microorganisms are not in there to go back into the blood and go around your body and cause problems. So these nodes will filter it. We have 600 nodes approximately throughout your entire body. And you know there are times when you get a cut in your hands or something or in your foot, you find the nodes get swollen because they pick up those bacteria that came in with that invasion. And they stop it from going into the blood.
So you're saying that the lymphatic system takes its fluids from the veins.
From the capillaries, it's lost, the exchange. When they're doing the exchange, the fluids are being lost from your plasma.
And then the lymphatic system, the lymphs pick it up and return it back to the blood. Okay.
Look at the lymph, please. Look at them. Lymph. Right. And then you look at the lymph. What is lymph? Where it comes from?
Lymph is the, want me to read it? Lymph is the fluid that flows through the lymphatic system, a system composed of lymph vessels, channels, and intervening lymph nodes whose function, like the venous system, is to return fluids from the tissue to the central circulation. And the origin of the fluid return process. And at the origin of the fluid return process, interstitial fluid, the fluid between the cells and all body tissues, enters the lymph capillaries. This lymphatic fluid is then transported via progressive larger lymphatic vessels through lymph nodes, where substances are removed by tissue lymphocytes, and circulating lymphocytes are added to the fluids before emptying ultimately into the right or left subclavian vein, where it mixes with the central nervous blood.
Make sense, guys?
Yes.
I will just explain to you guys, and I hope you listen very carefully to understand, with that connection. Very important connection. Because if you don't have
Central
the
nervous
fluid, if you don't have the fluid being put back into the blood, what do you think will happen? Swelling, but what else will happen? What else can happen? Come on, guys, think.
It can become acidic. pH balance, imbalance.
Hypovolemic. Hypovolemic. You know, you can go to hypovolemic shock.
Yeah.
Look up hypovolemic shock, please. Come on, guys, just work it.
Hypovolemic shock.
If you find the fluids are not going back, what will happen? It's going to drop because it's coming out from the blood vessel. So it means that the amount of fluids is being lost in the blood vessel. So see hypovolemia, please.
Hypovolemic shock.
That's hypovolemia.
Hypovolemia. Hypovolemia, also known as volume depletion or volume contraction, is a state of abnormally low extracellular fluids in the body. This may be due to either a loss of both salt and water or a decrease in blood volume.
That's a decrease in blood volume. That's all you want to this point. And you want to know what causes a decrease in blood volume? When you don't have the lymph body system increasing those fluids. So you get the hypovolemia. Now go to hypovolemic shock.
Hypovolemic shock is a form of shock caused by severe hypovolemia, insufficient blood volume, or extracellular fluid in the body. It could be the result of severe dehydration through a variety of mechanisms of blood or blood loss. Hypovolemic shock is a medical emergency. If left untreated, the insufficient blood flow can cause damage to organs, leading to multiple organ failure.
Alright guys, sit down and think about what you just heard
Infection.
and put it into the right perspective. If you have an X amount, how much blood should you have?
It's 46 liters. It's not 6 liters.
I'm asking you.
It's not 5 or 6 liters.
Why are you asking when you have a laptop in front of you?
Five liters. The volume of blood in the average healthy adult is about 5 liters.
Okay. How many pints make up a liter?
How many pints makes a liter? Two. 2 pints. There are 2 pints in 1 liter. Two point 11337476418
That is like 1 pound to 1 kilogram. I mean 1 kilogram to 2.2 pounds. All right. Now think about it. There are persons who go to sell their blood. 1 pint. Because they need money to get the hit. But for you, why I ask this question is because when a person has anemia is based on quantity and or quality of the blood. It's even true when we talk about the shape, production, microcyclic, and all the nice stuff. Quantity is based on things such as hemorrhagic anemia, bleeding, when you have any problems with fibroids or nemesis or bleeding. So you got to make these connections. Right? So you can see how you do your nursing configuration. Wherever form is coming in the exams, whether talking about it in maternity nursing or med-surg or pediatrics, you'll understand the concept. So you're not going to be struggling because you understand, you follow it. Okay? Right. Now in this blood, this plasma, you have these blood cells. And when you have problems with the red blood cells, we say you get anemia, right? I'm going through all the different anemias already, so I'm not going to go there. And then we just spoke about the lymphatic system. And there's another function of the lymphatic system. You kind of put it into the immune, right? Immune system. So that's where you now start to look at your lymphocytes. There's something talking about the lymph nodes filtering the blood. But the lymphocytes don't filter, they fight. And those are the ones that are known as your memory cells. That is your B and T cells. And they fight. But you have other white blood cells now, the leukocytes. They fight in different ways. You have the macrophage. Look at the macrophage. I don't want you to mix up the memory cells with the regular leukocytes. Because you're going to come across some fighting called phagocytes, phagocytes. The ones who engulf, who surround the microorganisms. What are macrophages? Anybody, what is a macrophage?
It's a type of white blood cell that surrounds and kills the organism, eliminating the cell and stimulating the action of other immune system cells.
The macrophage does what?
It's a type of white blood cell that surrounds and kills the organism.
All right. So what's a phagocytes?
The process called phagocyte.
We have, a process called phagocytosis.
Yes.
I have another definition here.
Phagocytosis.
Phagocytes are cells that protect the body by ingesting harmful foreign particles, bacteria, and dead or dying cells.
You guys got to know these cells because these are the cells that actually form your plaques that cause a blockage. The white blood cells go to these areas to eat up. And they help to form the plaques that end up in your CADs. There's a connection between all these things.
Phagocytes, and then phagocytosis, and then macrophage.
You guys did these things before, but you're not putting it together. That's a concern. You're not linking. When you move from one to another, you're not linking it. So every time you do it, it seems like it's something new you're going back over. It's not anything new going on back there, but it's just that you need to link these things. And
Give me
the
a number.
components also, and those are the white blood cells, and you know,
Text
you
it to
have
me on WhatsApp.
problems in the white blood cells and their, when you manufacture them, that is in the bone marrow. You can have a condition known as leukemia. And you have different types of leukemia. ML, AML. You guys remember that? I hope you guys go back over that.
You said different level of
We went
leukemia?
through the leukemias, we did it the different types. And if you guys don't remember it, now I can't fight you this man. You did it, and if you remember what was the most common type of leukemia, which is the one that you will, you know, can live a little longer,
Mm-hmm.
versus the one you're gonna kick the bucket.
I'm gonna send you two.
You did the most common form of leukemia.
I don't know. Yeah, 2022.
You don't have my number.
No, IKEA. It's not about it.
That's it.
I'm gonna send you another one.
Okay. She's an RN?
In here.
She's an RN?
Oh, of course.
Of course.
All right. So, what tests are we gonna do to find a person has leukemia?
It's a blood test.
Blood test and bone marrow biopsy.
Bone marrow biopsy. Alright, you want to go to the source because it's the bone marrow that is producing
Your white
go to
blood
the source to
cells.
see what's going on in there. There's something I want you guys to look at. Look for the word reticulocytes. Reticulocytes.
Reticulocytes.
R-E-T-I.
Reticulocytes are
O-C-Y-T-E-S. Reticulocytes.
Reticulocytes are immature red blood cells. In the process of erythropoiesis, red blood cell formations, reticulocytes develop and mature in the bone marrow, and then circulates for about a day in the bloodstream
All right, guys.
before developing
When you-
into
when you
mature red blood
are-
cells.
Doing bone marrows, you look for different things. You look for the white blood cells and all that. But if you come up with a blood test that have a whole lot of reticulocytes, it means now that your erythrocytes, or red blood cells, are not matured. If you have a high reticulocyte count, it means that the red blood cells are not mature. And if they don't mature, you will end up with anemia.
Anemia.
Right, guys?
Yep.
So do these bone marrow tests and for different purposes.
Reticulocytes, immature red blood cells.
Are you guys with me?
Yes.
So you got inside there, you have the thrombocytes. And the thrombocytes are the ones that cause you to what? Clot. Right? And you go through the clotting factor.
Reticulocyte.
Your final thing will be
Immature white blood cell.
Red blood cells. Red.
Fibrin, you know, from plastin to thrombin to fibrin to fibrin. Right. Now, let's look at the conditions. You're not going to go through the clotting factor. You know that. You already did that.
RBC is true.
And what we talked what we did before. The clotting, look for DIC.
Disseminated intravascular coagulopathy.
See what's DIC, guys? Disseminated intravascular coagulation. Talking about clotting.
Disseminated.
We want to talk about pregnant women. So let's see DIC. What's the definition?
Disseminated intravascular coagulation is a condition in which blood clot forms throughout the body, blocking small vessels. Symptoms may include chest pain, shortness of breath, leg pain, problem speaking, or problem moving parts of the body. As clotting factors and platelets are used up, bleeding may occur. This may include blood in the urine, blood in the stool, or bleeding into the skin. Complications may include organ failure.
Death is going to lead to. Cause of DIC.
Relatively common causes include sepsis, surgery, major trauma, cancer, and complications of pregnancy.
Yeah, pregnancy. I went back to pregnancy. We just did some pregnancy thing, right? We looked at pregnancy. DIC. When your thrombocytes are used up, because it causes what? Clotting all over the body. And is it you mean that the thrombocytes are going to use up now? And if it's all you have these clots all over his body, they're going to cause what? Blockages. But when it gets used up now, no clot is going to occur, and you're going to have what? Bleeding, hemorrhage, because there's nothing to stop there. The bleeding is going to not clot because there's no clotting factor going on. That's why they say you're going to have blood in there. Urine, you have blood all over the place.
Bleeding may occur.
And this can lead to the body shutting down, your body organs shutting down. When the body organs shut down, you're going to kick the bucket.
Platelets help for the
I want you to look at this here especially when you do maternity nursing. Look at DIC and maternity nursing.
DIC in maternity nursing.
Maternity nursing. And one time they also was focusing on sepsis. Remember at one time the facilities were teaching about sepsis. You know, we kind of touched on a few things tonight. Any concerns, anything that you need to just go over related to what we were talking about? Things that may not be too clear to you? I know it may seem to be like a lot. It is a lot. And unfortunately, you have to read much more. I'm not going to tell you, you got to read a lot more. Like I was telling the students yesterday, not yesterday, I said Mother's Day, the day before. You guys have to work much more harder than the people who go to the colleges. Much more. You have a harder time than the people in the college. Much harder time. They may have a lot of sources, but when it comes to work itself, you work much harder. You have to complete much more in a shorter space of time. So some people say, oh, this is an easy thing to get over with. I don't think so. This here is a challenge, a hard challenge. And so if you don't read, you're going to have some problems. Especially if you don't like reading. Especially if you don't like reading. It can be challenging.
Sorry.
That's why I introduce you guys to use the computers. Look up videos and this and that and make it easier and fun. And so you can get into the study. Because soon you guys are going to be doing your BSN. Because I know you're going to pass this. And when you're going to do your BSN, you're alone. You're alone in the computer. You're nobody else to do it. So if you don't like reading, you've got to read. And then you got to do presentation to people you don't even know. A whole set of people all around the country. All of you in the same computer, same line with the instructor. And you got to talk to all of these people. You got to do your presentation to all these people. So for people who sit down here and say, I don't like this, I can't do this, well, you're going to do it. So you better as well get to it now. Get to it now. And then you got to do every week they're going to ask you what, 2 or 3 assignments you got to hand in. And they do these chats, they call these chats and a lot of stuff. And before, you know what people used to do before? When they got to do maths, because they got to do the maths back again. People used to got to sum the data on continental people, helping them out. Now they set it up that you can't do that. And they're looking at you. And they want to see nothing in the background and this and that. So you can't cheat that way no more. They found out that people used to cheat a lot. So they stopped that. So you can't cheat that way. So you gotta be in front of it, compete it. So get used to reading out of guys. Get used to working with computers. Get used to it. Not difficult. You can make it. You know, you put the kids on these computers in half an hour, they're going to do what you did tech over a week to do. Because this is their life, this is what they come with. They grew up with this. So if you put them on the computer, all the things